as these technologies evolve and clinical indications evolve, it's changing so quickly and just giving patients more and more options for really individualized, personalized care.
Here's someone who was really an acute type of failure that was quickly noticed, sent to us from a different hospital in our system. And we were able to really, get that patient taken care of. And she was just a perfect example of teamwork.
When it comes to cardiovascular care on the organizational level, MedAxiom understands the challenges your program is facing. Welcome to MedAxiom HeartTalk, the podcast where thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom HeartTalk starts now.
I'm Melanie Lawson, a journalist in Jacksonville, Florida, and host of MedAxiom HeartTalk. Today is a structural heart innovations episode. We will discuss the challenges of capturing patient acuity in heart failure patients and innovative solutions to this problem. Our guests today are Dr. Vinod Thourani and Amy Simone, both from Piedmont Healthcare in Atlanta. Dr. Thourani is professor of cardiac surgery, the chief of cardiovascular surgery for Piedmont Healthcare at the Marcus Heart Valve Center, and a fellow of the American College of Cardiology. Amy Simone is director of the Marcus Heart Valve Center at the Piedmont Heart Institute, a physician's associate, and fellow of the American College of Cardiology. So welcome to you both. Really appreciate you taking some time out for me today, both Dr. Thourani and Amy.
It's a pleasure to be here. Thanks, Melanie.
Thanks so much, Melanie.
All right. So a lot of things that we can talk more about. You guys are impressive experts. That's why you're chosen to join us today. So I do encourage everyone to read their full bios and the episode notes, always something to learn there. But we do want to kind of get into this podcast now. So the first question, kind of warming everybody up, that we ask of all our Heart Talk guests, why did you decide to get into healthcare? What motivates you? And maybe there was that aha moment early in your career. So Amy, let's start with you.
Oh, great question, Melanie. Thank you. So my father is a cardiologist, and his passion and dedication definitely influenced my interest in science and medicine growing up. And, I was joke and say, what is it they say about apples and trees, But following my undergraduate education, I actually worked as a research fellow in molecular genetics at the CDC here in Atlanta. Specifically, I studied the genetics of type 1 diabetes, and I absolutely loved that work, right? But over the course of those 3 years in the lab, I realized I had a passion for treating patients at the bedside as opposed to their DNA in a lab. So I moved to Boston for PA school, and during my training, tried very hard to keep an open mind about where to specialize, but it was always the cardiology aspect of various specialties that I found the most exciting and appealing, and this is where I am today.
All right, I love it. And I'm sure your dad is very proud of you.
Oh, thank you. I'm proud of him as well.
Oh, I know. That's nice. All right, Dr. Thourani, what about you?
Yeah, so it's interesting that it's somewhat similar. So my father is a cardiologist in Mullen, South Carolina, a small town in South Carolina near Myrtle Beach. And I was there since age 7, and I really became interested. I was the baby of 4 kids, and really became interested in what he did, and would commonly be just thumbing through his textbooks on cardiology. It was called The Heart, written by some of the guys at Emory, J. Willis Hurst, actually. And so consequently, my interest in the heart became when I was, just 10, 11, 12 years old. Now I would go work in his clinic as extra money in the summertime, and really got interested in listening to the heart and reading EKGs with him. And consequently, that led me to come to Emory University, where Dr. Hurst had practiced at that time and had written these textbooks in the cardiac field. And then I had kind of an aha moment in my first semester of med school at Emory in 1990. And at that point, I was doing gross anatomy. And I said, boy, I love the heart, but I kind of like this cutting stuff too. And so holding the scalpel in my hand and working on the cadavers just really kind of was my aha moment of that I want to be a heart surgeon, but I want to stay, or a surgeon, but I want to stay with a heart. And so that's how I kind of developed into going into cardiac surgery. I knew that from a first year med school first semester.
Wow.
And that's been my passion, ever since then, is just bringing, that care to patients so far. So.
Dr. Thourani, did you just say you were thumbing through textbooks at 10 years old?
Yeah. Yeah.
Because I have a 10-year-old, and the only thing he's thumbing through is graphic novels.
Lego still probably. Yeah.
And I'm curious, any of the other siblings, did they get into medicine?
0, 4, or
Okay.
1 of 4, I guess. The other 3, and so that was. And my father's recently passed away, and it was still kind of reminiscent. But I will tell you something funny. He still says, you should have been a cardiologist. You're a heart surgeon. What is a heart surgeon? You should have been so I'm like, Dad, I'm sorry to disappoint you.
Right.
I'm a heart surgeon, not a cardiologist. And so he was still giving me a hard time at 87 that I didn't go into cardiology. So just to let you know.
Oh, gosh. Wow. Well, I'm sure that he's very proud of you. All right. So let's dive in. A 2021 multi-center study on acuity patterns of heart failure among emergency departments found that acuity-specific interventions will help decrease admission and revisit rates to the emergency department. So in other words, basically accurately capturing patient acuity helps save lives. So Dr. Thourani, let me talk to you about this. As you know, heart failure is prevalent among TAVR patients, but capturing patient acuity and mortality risks has its challenges. So as a physician leader with decades of experience, you've seen a lot. What do you think are the main barriers to really capturing that patient acuity?
I think this is really important, and and I think that is something that people don't concentrate on. I think that they concentrate on how to do a procedure. They concentrate on diagnosing aortic stenosis or mitral regurgitation or valvular heart disease, but they're spending very little time on the nuances of heart failure. Part of that is because there aren't very good metrics on exactly how to do that. For instance, we know that in aortic stenosis, if you have a mean gradient over 40, or you have a valve area less than 1, or V max of greater than 4.0, that we know that leads to severe AS. We don't have those great guidelines within the heart failure community on what is heart failure specific to valvular heart disease. So to me, it's unbelievably important. It does guide how, especially the acuity of it, is who gets admitted, who doesn't get admitted, how quickly you do their workup. Do you keep them inpatient, or can you do it as an outpatient? And quite honestly, it does eventually tie into how you code these patients for reimbursement, because there is a larger reimbursement for those that have acute heart failure that is predominantly diastolic heart failure compared to systolic heart failure. So I think we have scratched the surface on this. Amy and I have been working on this for over almost a decade now. But if I ask cardiologists or cardiac surgeons specifically about this, very few of them will be able to articulate to me exactly what they are dealing with valvular heart failure compared to just the valvular problem itself. So we need to do a lot of education. Congratulate you, Melanie, and MedAxiom for really starting to dive into this very important topic.
Yeah, I mean, I think that all of our topics really try to hone in on that and to educate. And so, as you're saying, we're kind of scratching the surface. Hopefully, people will dive in a little bit more. Amy, let me bring you into this, and your TAVR team as well at Piedmont. You have led successful documentation strategies for capturing patient acuity, trying to figure out how to do that. This includes bringing together the clinical documentation team, also the physician leader. So can you give us a glimpse into how you did this and the results, and just how you got this buy-in in general?
Sure. So thanks, Melanie. This is such an important topic and a great point of discussion. So, and as we know, referenced, we have been doing this for over a decade together, first at Emory and now at Piedmont. Okay, so this sort of initiative, it takes a village of stakeholders. So I have to first and foremost give credit to the entire team for their engagement and their dedication to the program and the patients for this to move the needle like we did. So, and also a little shout out to advanced practice providers. Disclosure, I am a PA, but APPs are critical to this process as they do the majority of the documentation, especially on the inpatient side here at the Piedmont program and many other programs across the country. So let me give you a little bit of background and kind of set the stage for our experience. So each month we have a Structural and Valve Center of Excellence, or COE meeting. And this is a quality and data review meeting where we look at our many things, of course, including quality, but specifically the structural DRG distribution. So that's DRG 266 and 267. 266 is with major complications and comorbidities, 267 is without. So it's reflective of our TAVR and mitral clip patient acuity, or essentially how sick they are, right? So last summer, we noticed a pretty dramatic shift in the distribution of DRG 266 versus 267. The 266 with MCC had plummeted. And it was very dramatic, kind of month over month. And we said, wait a minute, this is giving us pause. We raised, quite a few eyebrows here and said, what's happening? What's going on here? So, when it comes to assigning DRG 266 versus 267, with MCC for this population, the sort of biggest bang for your buck, if you will, is this documentation, appropriate documentation of acute on chronic heart failure and all the details that surround that. But that's key. So I think the first piece is why does this matter, right? So financially, the impact of that shift that we were seeing last summer, that drop in our 266 with MCC, was quite substantial in terms of reimbursement and contribution margin. And we really felt this shift was not accurate in describing the patient population or the acuity that we were treating and seeing every day. We felt we were leaving money on the table, so to speak. And everyone's ears really perked up when our financial analyst presented the numbers and said, this is what, previously looked like due to the shift now, this is what the current state of the world is. And, from that moment, we really had the support of leadership and administration to kind of go down this road and embark on, all the root cause analysis and education and process change, essentially whatever we needed to do to be more accurate and appropriate in our documentation. Okay, so we started with an internal audit and, identified what we felt like were missed opportunities around specifically the documentation of heart failure. So we brought in our CDI teams here at Piedmont, completely just a wonderful, phenomenal group. Also Modus One. So this is an independent company Piedmont partners with to evaluate and improve CDI. And so they were instrumental in kind of helping further deep dive into our audits and help us identify opportunities specifically around heart failure. So we discovered that the shift we were seeing was likely due to a changeover in some of our APP team, varying physician practices, specifically in terms of documentation and op report, and kind of a discordance as a whole, as a group, as to how we would define acute on chronic heart failure. So this was a great starting point, right? Lots of opportunity. So we needed to level set. And as a group, we leaned on one of our trusted industry partners who helped us embark on really intense education around documentation and MCC capture. This was provided to the APP team and also the physician team. Once the education was complete, we took these kind of overarching themes back to our COE meeting to discuss, because we really needed a consensus, right? We needed a multidisciplinary consensus and a real discussion about what did we feel truly constitutes acute on chronic heart failure? How do we document that appropriately? And we have to look at symptom presentation, physical exam findings, diagnostics, laboratory values, interprocedural LV-EVP, which is a new kind of criteria for us, and so on and so forth. So once consensus was reached in that group, I published kind of a summarizing document and shared with the providers for reference, and also the CDI team, right? Those coders and abstractors that are doing this work day in, day out. So I thought that it's imperative to have their partnership here. So the results, all in all, have been tremendous. I'm thrilled, and I really cannot thank my APP and physician partners enough for their investment and dedication to the patients in the program. The DRG distribution shifted and I think has risen appropriately and has remained fairly steady. And I believe it's much more reflective of the patient population and the acuity that we're treating every day. Administration and the leadership is pleased as well, but it really was such a group effort and took everyone coming to the table and really applying all these kind of daily changes to their process and practice, and the results have been wonderful.
Yeah, and a win-win certainly for the patient, as well.
So, Melanie, do you mind if I just add on something that Amy said? So we have, in our hospital system, we have 18 hospital systems as part of Piedmont, but we only have a limited number, 3 out of the 18, that actually do TAVR procedures. And in that, what we have is, and Amy said the COE, and that's called a Center of Excellence, where once a month, all the participants, imaging, the surgeons, the cardiologists, the advanced practice providers, the NPs, the PAs, our research coordinators, and valve coordinators, all those get on a joint call once a month. And we discuss common practices amongst the 3 sites. We talk about problems, good and bad. And we talk about this type of standardization across the network for things like heart failure. And that was a big discussion that we spent. And we get buy-in from everybody. We make sure that everybody understands that. I think that's really important message that we want to send, that it's a team effort for from the beginning till the very end, as far as diagnosing a problem that we think is for these procedures, and then finding a common solution that everybody's comfortable with, and then basically trying to roll it out as a team that all players are comfortable with. And I think that's a message that we want to send in this podcast. This should not be done in isolation. It should be done as a team effort and get everybody's buy-in on it when we think is appropriate. And then implementation, again, through a team effort. And I think that's something that's important. We see that happening not so well across the country, but we want this podcast to really hone in on that a little bit.
Yeah, I love that. And I think if we learned anything from the pandemic, we learned that the more we collaborate, the more we can do, because we had to do things on such shoestring budgets and with different people being out. So I think that's really important to know that it works in this area as well. Dr. Thourani, one thing you mentioned earlier as we were discussing, part of the challenge is that there's really no single diagnostic test for HF. So it's primarily a clinical diagnosis based on a careful history and then also that physical exam. So can you think of a time when you had to lean on both objective diagnostic metrics and also your own subjective assessment based on it all, your clinical knowledge to support your findings, and then why this combination is so important for the outcome of the patient?
Yeah, so what we've been able to do is find those criteria that allow patients to go from a regular MCC versus a non-MCC. So Amy has done a very nice job working with our heart failure cardiologist to kind of look at what are those different aspects that can lead to the proper coding for patients that come in. And so what we've been able to find, that heart failure, out of all the MCCs that are out there, heart failure seems to be one that we're able to put some legs behind as far as these specific patients. And what we were able to do actually with our work from our Piedmont Athens colleagues, we were actually able to come up with something more objective. And that is, for instance, looking at the end diastolic pressure. So when a TAVR procedure is performed, we actually in Atlanta did not measure left ventricular pressures at the same time as measuring aortic pressures. Our Athens colleagues actually do that for every case. And the number that comes up as an end diastolic pressure, a left ventricular end diastolic pressure around 18 or so. Above that is well accepted to be diastolic acute heart failure. And that's maybe a more objective number that we use. So now all of our programs measure left ventricular end diastolic pressures, and we document it in our operative note. And so there's when the coders and our APPs look at this, they know, and we've documented it in our op notes for our surgeon and cardiologist, that has become an important objective number for us. We also use EPIC. And in EPIC, we've formulated that the operative notes cannot be completed unless you have pushed in whether the patient is in acute or chronic diastolic or systolic or diastolic failure. So you actually can't sign your note until you've documented it. Some patients don't have it. You just remove that from your statement. So we've actually incorporated it within our EPIC templates for operative notes. And those are two specific objective things that we've done to kind of hone in on that. Subjectively, of course, we look at things like medication usage, the increased shortness of breath, increased PND, increased use of diuretics. Since a lot of these patients are outpatients, they come to us and we evaluate all of those. Some of that can be a little bit more subjective. And so those are things that we look at in addition to the objective measure. So we're approaching it from both sides. And we've learned not just from the Atlanta program, but we've learned from our other colleagues, and we're very appreciative of that kind of a collegiality between the two programs, three programs.
Yeah, again, that teamwork seems to be the key point here in this full discussion. So I think we are at a point where we might take a quick break, an excellent place to pause, and a quick message for our Heart Talk listeners. You hear the term care transformation a lot, but what does it mean exactly? Care transformation is redefining the way consumers buy and use healthcare by developing new products, treatments, and business models that integrate separate healthcare organizations or activities. MedAxiom understands that moving the needle in CV care is not simple. It takes vision and leadership, and it requires bridging technology, innovation, and care delivery. MedAxiom experts are helping programs across the country shape the future of cardiovascular care delivery. Through education, organizational performance solutions, and advocacy, we are evolving disease management, innovating virtual care, driving the data revolution, and redefining access and team-based care. Let's transform cardiovascular care together. Get started at medaxiom.com/care transformation. Welcome back, everyone. We have been talking big picture about the challenges to capturing patient acuity and some of the innovative strategies to overcoming them. And one of the big points we've been talking about is collaboration and buy-in and how to get everybody on the same team. And we've learned some really good practices to make that happen. Let's dive just a little bit deeper. And first, let me kick it off with Dr. Thourani. What are the questions that physicians should ask when acute or chronic HF is suspected?
So, and I think that one of the first things that all physicians, and they should, because they're looking at validity, should look at the ejection fractions across the board on the echocardiograms. So if you've noticed that on the systolic side, if you notice that a patient had an ejection fraction that was 55 or 60%, and now is in the 25 or less than 50%, then that's kind of a change in the systolic component of it. There's, of course, in the diastolic component, that we look at, diastolic heart failure component, that's a little bit on the echocardiograms, you can't get that as much, but you can by talking to the patient. Have their medications, their need for diuretics increase? Are their feet swelling more? Are they getting more short of breath? Have they gone from sleeping from no pillows to two pillows, or one pillow to three pillows? Some of our patients sleep sitting up in a chair at nighttime. And when they lay down flat, they get more short of breath. And how have those symptoms progressed over the last month before their index procedure? So I think those are the type of questions that we really want to elicit from patients as they come in for their procedure. And Amy may have more on some of the biometrics that we look at for these patients also.
No, I agree with you completely, Vino. I think being very pointed about the questions around the patient's symptoms could not be stressed enough. And I like to look at changes over time. And it's important for patients to to give you an answer based on the last 2 weeks. How have you been feeling last week? Also, I always like to ask patients when you're walking into the hospital today, because we all do an H&P update the day procedure for the index procedure. When you're walking into the hospital today, did you have to stop and rest? Were you short of breath? Have you yourself adjusted your diuretic medications and so on? I do want to talk about one laboratory value I think is extremely important is the BNP, the brain natriuretic peptide. We do check this on every one of our preoperative patients just before the index procedure. I think this gives a really nice reflection, in and of itself. Day of or day before is ideal to get just a really nice clinical picture of that moment in time, because things change dramatically over a course of days or weeks. These patients are very tenuous. If it's elevated, this patient is suffering from acute on chronic heart failure, whether diastolic or systolic. You need to differentiate there. But it's an extremely useful tool. There's been some discussion around cost of this diagnostic test, but it's extremely powerful in this exact conversation, giving us a framework for where does this patient stand in terms of acuity for a heart failure diagnosis.
All right, great information. And it's interesting just listening as a journalist, everything you talked about are things that I would think would stand out as something wrong from a patient standpoint. But, I don't think it always clicks to patients because that's how they're living their life. So it is really important that the doctor asks those questions to see if that's something that they're dealing with.
One comment to that, Melanie, that's a really great point. And we've heard this time and time again over these last, over the last decade plus. Patients think their symptoms are normal. They say, well, I'm 80 years old. I think I'm expected to feel this way. They attribute so many of these symptoms to their age, shortness of breath, fatigue, even chest pain. They say, well, I'm just getting older. It's a great conversation to have with them and say, no, this is not related to just your age. There is an issue here, and we can help.
Yeah, I have a 79-year-old mom who tells me all the time, I'm just tired because I'm old,
Right.
And I'm like, no, let's figure it out. You can live a full life.
I mean, Melanie, I'll tell you also that there's been a huge, and I think I know this for a fact across the other hospital systems that I know, that the stuff that we're talking about now, and Amy and I talked about it not, recently on one of our Center of Excellence calls, is the education to do what we're just talking about has to be repeated every couple of months. And the reason is our providers, not necessarily our physicians, but our nurse providers, our valve coordinators, the turnover has been so high across the board, across the country, because there's so many people who are moving and shifting all the time, that this education, what we're talking about today, has to happen maybe 3 or 4 times a year. And I think in this era of what we call the Great Resignation, right, where people aren't coming back, we're getting a lot of traveling people, a lot of traveling nurses. So I think it's really going to be important for the listeners to know that you can't do one training and say, all right, we're good now. It's going to have to be maybe quarterly, have a training session, or twice a year. So it's going to be really something that's important for the listeners to understand that.
And I think maybe the physicians who are doing it already could be a part of that training. And then that's also a chance to have that conversation and to test themselves. So
right.
I think that's so important, considering new people are coming in all the time, that they get the same level of training. Amy, let me ask you, because we talked about questions to ask. So think about your peers in terms of things they must do. So and we're making a cheat sheet, let's say, for capturing HF patient acuity. What would you include in that sheet?
Oh, this is a great question. Okay, my recommendations would be as follows, and I actually bulleted these out. So firstly, number one, a regular review of DRG distribution, I think, is a great practice to keep this topic front of mind for the entire team and to keep everyone engaged in this process. It needs constant attention, right? So 2, I would recommend you design a pocket card detailing and describing the MCCs for providers, APPs, physicians, whoever, to reference really quickly while they're documenting, while they're creating their HPs, their progress notes, their discharge summaries. EMR templates, these are a great reminder and prompts to include all the right tidbits of information, because it's a busy workflow, busy day, you might forget of something. So having a template that gives you a chance to stop and reflect that, oh, did I answer this? Did I answer this? And reference this in his off note as well, that, he can't necessarily move on to the next piece of the note without answering certain questions. So having a template can really, really help you in your EMR. And we use Epic here at Piedmont, but, they all have that capability. So, involving your CDI team is incredibly important. I would put that on the list of best practices for sure. The abstractors and coders, they need to know what to look for and where to look for it. Another tidbit would be providing regular audits, whether that's an internal audit that you're doing or you have an external partnership to identify opportunities or things that are slipping, right? Next, the consensus as a group, which we touched on with our colleagues here at the Piedmont Heart Institute. What constitutes acute on chronic heart failure, and other MCCs, and how do we document that? Put that in writing for reference. Summarizing the consensus and publishing it, quote unquote, so to speak, is a really nice reference there. Next, and Vinod touched on this, to ensure the procedural or op report is reflective of the true acuity of the patient, and that's really documented at the point of the H&P. So it needs to mirror that information. So another kind of my next point would be to ensure consistency throughout the entire medical record, starting with the H&P, moving through the op report, the progress notes, and the discharge summaries. All that the information needs to be consistent there. Now, if you take this intraoperative piece about LVEDP that Vinod mentioned, if there's an elevated number there, that needs to be reflected appropriately in the discharge summary and all the notes moving forward, so that consistency is there throughout all the providers. I think emphasizing the importance of this whole initiative with physician and APP team couldn't be more appropriate. Regular trainings, I think we at our weekly APP meeting, we touch on this every week, where I say, last month's DRG distribution is this, and I do little, internal chart biopsies and take a look at some of the APP notes, and we'll bring up some things that I see in terms of opportunity or how they're documenting, just to keep that front of mind. Lastly, I really do feel that this multidisciplinary approach is just key here. So that's absolutely part of the best practice to reach these consensus and move this needle forward in accurately describing the patient acuity. So we have lots of little bullet points there.
Thank you, Amy. I think that multidisciplinary approach is so important in all phases of medicine. So if a patient's not hearing that, then there's probably a problem. Amy, I think you touched on this, but if you have another story, I want you to think about it because, we're literally talking about saving patients' lives. These are our potentially sickest patients. So Dr. Thourani, let me ask you, any specific patient story that stands out? Maybe someone was just, they knew, how important this was, and they just were so thankful that the team was able to capture this acuity for that patient.
I think that the patient that kind of stands out a little bit, there are a lot of patients that stand out. There's a patient that came to us who was pregnant. I think Amy will know which one I was talking about, who's pregnant, unbelievably sweet young lady who was worked in the hospital system and was from one of our sister hospitals a couple hours away, and couldn't walk to the bathroom, partly because she was pregnant, but also because she had severe valvular disease. And this is someone that we used a very large multidisciplinary team of, we had imagers, we had cardiologists, we had invasive, non-invasive, we had anesthesiologists, we had OBGYN, we had cardiac surgery. And, here's someone who was really an acute type of failure that was quickly noticed, sent to us from a different hospital in our system. And we were able to really, get that patient taken care of, had a TAVR procedure, had a delivery done, just a beautiful situation. And she was just was a perfect example of teamwork, making the right diagnosis, making the right treatment algorithm, getting the right people involved, and having a great outcome. And she's now consequently had a baby, and she's doing well. And this is someone we're gonna follow for the rest of her life, at the valve center here at Piedmont. And so those are the type of things that I'm the most proud about, even though, quite honestly, every day that a patient has a procedure and they do well, I'm proud of that. But there's some special patients that are kind of in that top percentile that you'll never going to forget about.
Yeah, life was just beginning, and in the end, keeping a family whole is certainly rewarding.
Right.
Both of you all, Dr. Thourani, you frequently share cutting edge information with your peers. You do webinars really on how to navigate complex cases. A lot of people learning from you. Amy, you're leading transformation in this space. You've been doing it a long time. Don't look like it, but you have for nearly 20 years. Let me start with you, Amy. How does it feel to be a leader in this space? And again, it's clear in what you're saying, but why are you so passionate about the work that you do?
Well, first of all, thank you for the compliment, Melanie. I'm honored to be considered a leader in this space. And, I share that privilege with other cardiovascular team members across the country who started as I did in the early days of TAVR as valve program coordinators and have evolved professionally kind of along this trajectory. So thank you. For me, when I first dipped a toe into the structural world in 2011, I knew I could never go back. I knew this is exactly what I wanted to do, this niche for the rest of my career. And I think what struck me so profoundly in those early days of TAVR within the partner trial was that just months before, patients, just like the ones we were treating, were essentially told there were no options for them, right? And that they were, asked to go home and get your things in order, spend time with your family, and now there was an option. Now there was something to do. And it was just that TAVR technology was so disruptive. And I mean that in the very best sense of the word. The structural field has come so far in a relatively short amount of time. There's been such innovation here in this space, but this has been the most gratifying work of my career exactly for that reason, Melanie, because it comes down to the impact on a patient's quality of life, right? Watching firsthand the difference that these catheter-based procedures are making on patients' lives across the care continuum has been just exceedingly gratifying. And I feel incredibly fortunate to be involved in this work every day and, really look forward to what the future holds as these technologies evolve and clinical indications evolve. It's changing so quickly and just giving patients more and more options for really individualized, personalized care. So I feel extremely lucky.
Yeah, Dr. Thourani, let me ask you, and at this point, I'm hearing this, knowing that this is an option for some patients that may never learn of these options and may never have the chance to get these procedures. So I can imagine that's why education is so important for you.
Yeah, education is, Melanie, I think it's so important. There are a lot of us go to a lot of these national meetings, but let's be honest, most physicians can't take, 4, 5, 6 days to go to these big national meetings. So I think we have some work to do in bringing education locally and doing things like this, which are podcasts and virtual meetings that can reach the majority of physicians who can't go to all these big national meetings and take away time from their practices, because there may be one or two physicians taking care of a lot of patients, and they can't just leave their practice in a small town in Oklahoma to go to a big national meeting and hear all these luminaries. So I think that education is critically important. And I think we have to redefine what education means, maybe in addition to these large meetings where people can go, supplementing them quite a bit with podcasts and virtual Zoom meetings, which can be done in an evening. That these physicians who are taking care of thousands and millions of patients to get them the newest information about these technologies. So I think with the era of virtual and education, I think we need to redefine how we educate people. And I think that I'm not sure, do a great job teaching people, especially in the non-metro areas, in the suburban areas, where in the rural areas, I don't think we're doing a great job with education. I think that is something we discuss on a national level of how we need to do that better. And I really congratulate MedAxiom and other pathways to allow us to better educate people in a rural setting, because that's really where I feel like we're missing a lot of issues. I think people in Atlanta, for instance, know what a TAVR is, right? But I'm not sure that 4 hours here in a small town, they do know what that is. And I think a lot of people are unfortunately saying that there's no option except open heart surgery and not being given all of the opportunities. Maybe surgery is the right thing for them, but they should have really a balanced approach of how to manage their disease process. So you're right on, Melanie. We need to find better conduits for education, not just in Chicago and Atlanta and Boston, but in America. And I think that's really where we need to put a lot of energy into.
Exactly to that point, I think if there's one, well, maybe there are a couple, but the one silver lining of COVID, it really forced us to examine modalities of communication and education. And I feel like those things will stay with us and are really going to shift how we communicate and educate moving forward. So I completely echo your sentiments there.
Well, the access is there, the opportunity is there, and I was a health reporter as well as an anchor at my station. And I can remember the first time I did a story about TAVR, and I had no idea what I was doing, but the doctors were so excited about it, and they got me excited as well. And I never will forget doing that story, because I think it was it felt good to let people know that this was available. So it's good for patients to understand that this is an option for them. So Dr. Thourani and Amy, thank you all so much for joining us today. This has been great information. I hope that the people listening are motivated to learn more about you, to learn more about everything that we talked about. So thank you for sharing your time and your expertise today on MedAxiom HeartTalk.
Thank you so much, Melanie. And thank you, MedAxiom, for the opportunity to be here today. It's been a pleasure.
Thanks, guys. Really appreciate it. Really do. Thank you.
All right, I think we may be talking again soon about this topic for sure. So that is it for this episode, though. If you liked it, please tell your colleagues and let them know that they also can subscribe to MedAxiom HeartTalk on Apple, Google, or wherever they get their podcast. Also, if you'd like to send us a note directly or even suggest a topic, email us at hearttalk@medaxiom.com. Thank you so much for listening today.